Hi dear doctors, welcome to 𝗧𝗲𝗹𝗿. Myself Dr. 𝗲𝗲𝗴𝗿𝗺 and we are in the class of Pediatrics. So the topic of discussion for today is what are the different causes in pediatric age group for which the pediatric patient will land up in nausea, will land up in vomiting. So what are the different differential diagnoses? So this is a symptomatology. We are discussing about a symptom, that is nausea and vomiting in children. So of course, when you are doing a case presentation of GIT, they can ask you what are the different causes of nausea and vomiting, and of course, some of these things are given as clinical hints in your case-based scenarios, which are often being asked in different MCQ exams. So what is nausea? You very well know that's an unpleasant sensation. Okay, it's an unpleasant sensation which is associated with tachycardia, which is associated with your tachypnea, which is associated with decreased gastric tone. Whereas vomiting on the other hand is actually oral expulsion. So this is a, if some old examiner comes to you in your viva, they are definitely going to ask you what about the definition of vomiting, okay, or they sometimes ask that define vomiting. So vomiting is actually expulsion of gastric contents due to abdominal and chest wall contractions. Okay, so it's a oral expulsion, it's a forceful expulsion. So forceful expulsion of the gastric contents due to abdominal as well as chest wall contractions. So what are the different regions which are responsible for triggering your emesis? So first important part is the vagal efferents. So what do you mean by vagal efferents? See, whenever the food is going to be coming and food poisoning is going to happen, or some drugs are coming, they are going to cause some irritation to your vagus nerve. Okay, and once the vagus nerve is getting irritated, it is responsible for causing vomiting. Similarly, in the fourth ventricle's floor, so if you remember your anatomy, in the floor of the fourth ventricle you have got an area that is called as area postrema, or it is also called as CTZ area. This area is sensitive to the different toxins, different chemicals. So this is also responsible for causing vomiting. Also, you must have seen while going to the mountains that when the car is revolving and inside sitting in the car you feel like vomitish. Why? Because in those cases your vestibular system is going to get activated, located inside the inner ear, and you are going to suffer from motion sickness. And of course, your amygdala is also responsible for vomiting in some like olfactory cases. In some emotional triggers, vomiting can be there. So I still remember when there's a dish called as saag. Okay, that's a Punjabi dish. Saag is a green leafy vegetable. So whenever it is cooked in my house, I feel like vomitish. Why? Because the olfaction, because the smell is so noxious to me that my amygdala gets stimulated, and amygdala is something that is responsible for your vomiting. So V for vomiting, of course, V for vomiting and V for vomit, you can remember V for vagal, V for vestibular system, and V and A are just the mirror images. So A for amygdala and A for area postrema. Coming on to what are the common neonatal and infantile causes. So one is going to be GERD, that is gastroesophageal reflux disease. These are very commonly seen in neonates. And milk protein enteritis, again important, milk protein enteritis. So next is the milk protein enteritis. Some children, they don't find milk protein suitable. So whenever you're going to give milk protein, that will cause the inflammation of the gut. And of course, once inflammation is going to happen, this may lead to vomiting also. Pyloric stenosis, again, if the pylorus is stenosed, so this is your stomach, and if the pylorus region is stenosed, of course, the contents are going to come back through the vomiting. Other thing is adrenal insufficiency. It has been seen that if there is adrenal insufficiency, it is somehow related to vomiting, but not very important, so we can skip that. Coming on to intestinal obstruction. So intestinal obstruction, like Hirschsprung disease, like intussusception, like atresia, in all these cases you will have what? You will have vomiting. And of course in some inborn errors of metabolism also. Okay, in some inborn errors of metabolism also. Okay, so just you have to remember when it comes to this causes. So any cause of a stenosis. So I should speak like this. This is esophagus. So one of the cause for esophagus is GERD. Then comes the stomach, and from stomach you can remember pyloric stenosis. So this is pyloric stenosis, and of course P for pyloric stenosis, P for your protein enteritis, milk protein enteritis. And then comes the intestine. So the causes which are related to intestinal obstruction, like your 𝗲𝗃, your Hirschsprung disease, and your intussusception, everything is going to get related to this. And I for intestinal obstruction, and I for one more, that is called as inborn errors of metabolism. Okay, inborn errors of metabolism. But what are the causes in adolescence? So you have got something which is called as dyspepsia, that is faulty secretion of acid, dyspepsia. So that a lot of acid is going to get accumulated, and the acidity, the gas, that leads to bloating, and whenever there is this tension, the stomach tries to contract and expel the amount of food outside. After that, you have got IBD, that is inflammatory bowel disease or irritable bowel disease. Vomiting is one of the factors which is there. Appendicitis is also going to present with appendicitis is for nausea and vomiting. And if you remember this score of Mentrel's that's discussed in medicine, Mentrel score, the N is something which is called as nausea and vomiting. Then bulimia, that's a psychiatric illness when it is associated. Okay, B for bulimia, B for binge eating. So the child or the patient is going to binge eat, and after binge eating they are going to induce vomiting by putting the fingers inside or by some other means. And then you have got something which is called as rumination syndrome. In UG days, rumination syndrome, just the name itself is sufficient. Okay, so can you see this is HCl which is secreted more, then appendix is there, then bulimia is going to be there, rumination, all these things are actually important. But remember, A, B, C, D is important. A for appendix, B for bowel disease, B for bulimia, D for dyspepsia, and C for cow. Cow has, that cow is a ruminant, so you can remember rumination disease. So there are different clues which are given in different MCQ exams. These clues are really important. Okay, so if there is an undigested food coming out in the vomitus, that means it's 𝗲𝗃𝗃. Okay, that means it's a 𝗲𝗃𝗃 where your sphincter tone is going to get increased, and the sphincter tone is increased. That means the entire food is going to be there inside the esophagus and it's not going down in the stomach, so it becomes undigested. It is not digested, it is undigested. Then comes bilious. So what, the post-ampullary obstruction. See, intestine, and rather I should say the second part of the duodenum. Okay, second part of the duodenum has got ampulla, and in ampulla there is opening of the bile duct. So any obstruction after the opening of bile duct will have the food mixed with the bile duct when it comes to vomitus. Otherwise, gastritis and ulcer, both of them are going to have bleeding. So this bleed, if it is happening for a long span of time, this bleed is going to get converted into hematin, and hematin is of which color? Hematin is of actually coffee color. So it's easy to remember that gastritis and ulcer, both of them are going to present with the coffee ground bloody color. Fall odor, of course, the smell, the breath is going to be bad if there is a bacterial overgrowth. Intestinal obstruction, of course, if the distal parts of intestine is obstructed, it is going to be feculent. Regurgitation, so effortless, you are not going to put some efforts, ultimately the food is going to come out on its own, like in GERD and rumination disorders. Projectile, very very important, please remember projectile. P for pyloric stenosis, O for obstruction. Okay, and some metabolic diseases also. Actually, from pyloric stenosis, of course, we have discussed this pyloric stenosis in detail, and there I told you that there is hypokalemic, hypochloremic, metabolical, acid alkalosis. So these are the metabolical issues where then there is vomiting. Projectile vomiting is something which is going to happen. Then milk, soya, gluten allergy. So basically, if the child is protein intolerant, so there will be a positive history that after consumption of milk or soya or gluten, these problems are going to happen. Then of course, there is some people are actually fructose intolerant. So many foods are going to cause this problem. And of course, eosinophilic gastroenteritis. So any food that is responsible for causing the allergy, so food allergy. So whenever there is allergy, of course, your eosinophils are going to get increased, so eosinophilic gastroenteritis. And if it is associated with nausea, there's a high probability that the child is suffering from some cranial issues, some brain issues. So sorry, without nausea, but with increase in intracerebral pressure. So we have a strong clue that it is the intracranial mass which is actually responsible for it. So what you have to do, you perform a CBC in order to check if there is anemia, because if there is anemia, it is suggestive of blood loss, and blood loss is something which is seen very commonly in cases of gastritis, inflammatory bowel disease, peptic ulcer disease, some infections and sepsis also. Then you have to check the amount of electrolytes, because it is something which is associated with dehydration, pyloric stenosis, metabolic diseases, and of course with the adrenal insufficiency also. And of course, please check your amylase and lipase level, that is going to be high in pancreatitis. And here comes a question, which enzyme out of these both, okay, which enzyme out of amylase and lipase is the one which is most commonly associated with pancreatitis, okay. So I'm not going to write the answer to this question, and I'll wait for your replying in the comment box. After that, coming on to imaging. So please understand obstruction. If you suspect obstruction, of course you will perform a plain abdominal X-ray, and I think from the previous classes, you know, like 2, 3, 4. Okay, so these are actually the, I should say, 1, 2 and 3. Single bubble sign is actually stomach obstruction. Okay, single bubble sign is stomach obstruction. Second, 2 means die means duodenal obstruction. Okay, double bubble sign, or similarly you can remember duodenal obstruction. Then you have got 3, so 3 is seen in the jejunal obstruction. Okay, jejunal obstruction. Okay, so duodenal obstruction, jejunal obstruction, all these are important. USG abdomen, of course, pyloric stenosis is going to get seen on the USG abdomen, and if you remember, there is some sign which is called as antral nipple sign. There is a sign which is called as target sign. So these both are the signs which are seen on the pyloric stenosis. Intussusception, again USG can be performed, but intussusception is actually seen on the barium enema also. And what you are going to see in the barium enema, you will see what? You will see a claw sign. Okay, so you will see which sign? You will see a claw sign. And some hepatobiliary causes will also be seen when you will perform a USG abdomen. Then gastric emptying studies, in order to see like how much time it is taking, how much time the stomach is taking for gastric emptying. We do the gastric emptying studies, and that is called as gastroparesis, in order to see the gastroparesis. That means if the stomach muscles are paralyzed or not. And of course, the CT scan of head is also important in order to see the intracranial mass, of course, the increase in the intracranial pressure. So these are the different causes of vomiting, and how will you evaluate a child with vomiting. Thank you so much for watching. God bless you.